My name is Dr. Kudzai Mrembwe from Zimbabwe. I'm presenting for OFIT, which is the Organization for Public Health Interventions and Development. I'm presenting on a study that we did as part of the COVID Go project. This was to assess the knowledge, attitudes, and practices towards COVID-19 vaccination among pregnant and lactating women in task-supported districts of Zimbabwe. This was a descriptive cross-sectional study done between August and September 2022. So the background to our study is that as Zimbabwe, we rolled out our COVID-19 vaccination program in February of 2021, when the rest of the world was responding to the pandemic by vaccinating their population. So we introduced the COVID-19 vaccination program in February of 2021, but in our initial rollout, we were not vaccinating pregnant and lactating women, mostly because when the clinical trials were done for COVID-19 vaccines, pregnant and lactating women were not included. They were excluded from the trials. As such, the vaccines that were being used in Zimbabwe were not recommended for use in pregnant and lactating women. In June of 2021, WHO recommended the use of COVID-19 vaccines in this subgroup. However, as Zimbabwe, we failed to establish a clear public policy to promote vaccination within this subgroup. So in that regard, we have had a low uptake of the COVID-19 vaccines in this subgroup. In order to tailor advocacy and communication strategies aimed at improving vaccination uptake in this subgroup, we would want to understand the uptake of COVID-19 vaccines as well as the knowledge, attitudes, and perceptions towards the same. Yes, this is what prompted us to do the study. Our objectives for the study were to determine the knowledge, attitudes, and practices on COVID-19 vaccination among pregnant and lactating women accessing services in task-supported health facilities between the 1st of August and 30 September 2022. Our task-supported health facilities are within 4 provinces of Zimbabwe, that is Matabeleland South, Bulawayo, Harare, as well as Masvingo. Our specific objectives were to determine among pregnant and lactating women in task-supported health facilities the COVID-19 vaccination uptake rates during pregnancy or lactation, their knowledge, attitudes, and practices on COVID-19 vaccination uptake, as well as any barriers that may be in existence in order for them to take up the COVID-19 vaccines. In our methodology, we used a descriptive cross-sectional study, which we conducted through an interview-administered questionnaire, and our minimum sample size was 780 pregnant and lactating women. These were chosen from the task-supported health facilities. What we did was to use a 2-stage cluster sampling with probability proportional to size in order to choose our sample sites. So initially we chose health facilities, and the facilities that we chose were based on the number of HIV positive people that we attend to within those facilities, because our project, which is TASK, is mostly focused on HIV management. So we were using that to actually identify the high volume facilities where we have the highest number of individuals that are accessing care to HIV services. Then our second stage was to then choose the particular mothers that were actually going to be interviewed for the study. So our inclusion criteria were pregnant and lactating women identified at task-supported health facilities between 1 August and 30 September. So for our demographics of those mothers that the mothers that participated in our study, we found that they had a median age of 25 years. And of those, 46.2 were pregnant, while 53.8% of those were lactating. And then in terms of those who were pregnant, we found that about only 10.3% were actually less than 12 weeks, which shows that we still have a low number of females who are booking before the recommended time. We usually recommend that they register by 12 weeks, but you find that we had very, very few that it actually registered in their first trimester. The bulk of them were in their 3rd trimester. There's about 56.2% of the pregnant mothers that we interviewed. And then in terms of their HIV status, because like I said, TASK, our main focus is on HIV management. So amongst the mothers that we interviewed, we found that about 95.6% of them already knew their status, which is one of the milestones that we have reached as Zimbabweans, to say that we have 95% of our population knowing their HIV status. And then amongst those mothers, who we interviewed, 22.6% of them, they were positive and all of them were on treatment, and 73% of them, they were negative. Then in terms of our main focus of the study, which is actually to one of our objectives, which was actually to understand the vaccine uptake rates of these mothers, we found that 56.5% of these mothers had been vaccinated. Our target for vaccination is actually to vaccinate about 70% of the population. So in this subgroup that we interviewed, we only found 56.5% of them having been vaccinated. The other 43.5% had not been vaccinated. And our definition for vaccination in this case was to say at least someone who had received at least one dose of the vaccine. And then in further inquiry amongst the mothers, we found that about 67% of them had actually received a first and a second dose, with only 15.8% having received their third dose. However, for those mothers, we also found that 66.3% of those that had been vaccinated had actually been vaccinated prior to their pregnancy, and 12.3% had been vaccinated during lactation, with only 21.4% having been vaccinated during pregnancy. And then in terms of our knowledge, attitudes, and practices, we found that our mean knowledge score was 74.9%, with the most non-attribute being the COVID-19 symptoms and how COVID is spread. The mothers that we interviewed, they were very knowledgeable about that. And then in terms of their attitude score was 74.1%, and their mean practice score was 76%, because we found that most of those mothers, they actually said, in as much as they didn't feel safe receiving the vaccine during pregnancy, they were okay with recommending their eligible family members or their children to actually get the vaccine because they felt it was safe for them. Then we found that women with better knowledge levels were 3 times more likely to have a higher positive attitude towards COVID-19 vaccination. And those with higher attitude score and higher knowledge levels, it's also a higher COVID-19 vaccination uptake. Those are the females that you found had actually taken their second dose or had subsequently received their booster dose. However, in terms of their risk perception for both vaccinated and non-vaccinated mothers, we found no significant difference in their risk perception. Then in terms of the factors that were associated with vaccination, we found that older women aged between 30 and 49 years were actually more likely to be vaccinated relative to younger women. And then in terms of level of education was also a contributing factor to those mothers that were vaccinated. The finding was that those that had a higher levels of education, those that had attained tertiary education, were actually more likely to be vaccinated compared to those that had a lower education. And then in terms of place of residence was also an associated factor, with the finding being that most rural women were actually vaccinated relative to women who resided in urban areas. And in most of those rural settings, you find that there are several health programs that go on, including outreaches that go on, which meant that the vaccination services were actually closer for those women who were residing in the rural areas. Then in terms of the barriers to COVID-19 vaccination, we found that fear of adverse events, which was reported by 40.5%, was the major contributor or was the major barrier to COVID-19 vaccination. The feeling being that initially the women were not included in the studies that were done, and eventually when the recommendation to actually vaccinate them came, Zimbabwe as a country did not then do any promotion or any events or any educational sessions to actually advise on the changes that had been done and the recommendations that had been done. Then also there were myths and misconceptions that are circulating within the communities. These were also cited to be a barrier to COVID-19 vaccination. Other issues that also came up were to do with distance from the health facilities. Then the myth that the people who had been vaccinated would die within 1 or 2 years. Those were also some of the issues that were raised, but the major two were the fear of adverse events and the myths and misconceptions circulating within communities. So to conclude our study, we found that COVID-19 vaccine uptake during pregnancy and lactation was very low, with only a few mothers, that is about 21.6, having been vaccinated during their pregnancy, the bulk of them having received their doses prior to them getting pregnant. The fear of adverse events and perceived risk to unborn babies are the major risk barriers to vaccine uptake. And bearing this in mind, these two misconceptions that circulate, there is a need to tailor messages that target mothers to advise them of the benefits that vaccines have, and also to show them that vaccines, whatever risks the vaccines may have, they outweigh the benefits that the vaccines have. Also taking into cognizance that pregnant and lactating mothers are at higher risk of having severe COVID-19 symptoms or severe COVID-19 outcomes when they do contract the condition. Then also as a country, we need to have a clear public policy or guidance on vaccination of pregnant and lactating women, because the current guidance that is in existence says that we need to offer women an alternative until such a time when they are no longer pregnant or they are no longer lactating. And it also insists that for those who may want to be vaccinated, they actually need to get a consent, so that then in a way says, we are not really confident with this vaccine, we would want you to do this at your own risk, because no other person is being asked to sign a written consent when they are getting a vaccine. So when we are making our pregnant and lactating mothers do that, we are communicating something different to what we are preaching in terms of the safety of the vaccines. Then also there is a need to integrate COVID-19 vaccination in the ANC and PNC packages, so that it becomes routine, like what we do with HIV testing, what we do with the tetanus toxoid boosters. That should be the same way that COVID-19 vaccines are administered to these pregnant and lactating women. These are our references for the study that we did. Thank you very much for listening.